This show is sponsored by the law firm of Tony Kalagarakis and Associates.
Sometimes we never get a chance to meet our clients. Wrongful death is not easy for the family. At the Injury Lawyers of Illinois, we focus on what we do best, car and truck accidents. We're very selective with the cases we take on. We understand and approach every case as if it's the only case in the office. We spend so much time on a given file that we relate to that particular client. The ultimate goal is to make the client whole, is to put that client in the same position as they were prior to the accident ever happening. A client has to understand where their case stands. We speak their language. We have individuals in our firm that are fluent in 8 different languages. The client is aware with regards to what's going on in their case at every level. A lot of people out there don't realize that the big insurance companies are not primarily focused on their treatment, their health. We are. After all, it's the client's interests that we have in mind. We know how to start a case, and we know how to end a case with a successful resolution. We have the resources, we have the knowledge, we're local. We've handled thousands of cases regarding car and truck accidents. That's what we do. My name is Tony Kalagarakis, and I'm the managing attorney at the Injury Lawyers of Illinois.
שלום עליכم. أنا ريبيكا سايمون. مجيبة يوداء شاميران قابلوخين ومشينا. أرخن أمان أوديو إيل ساينتست بشمت أسيا واكين كيم مادريناس. همزم تبدوية باسط كوفيد إجاسر بلشانة إنجلس. Hello, my name is Rebecca Simon. On behalf of Shamiram Media, I welcome all our viewers. Our returning guest today is a scientist, Dr. Kim Madrenas. Dr. Madrenas is a nephrologist, an immunologist, and an infectious disease doctor. He was the chairman of the Department of Immunology at the McGill University in Canada. He founded 2 immunology-related centers in Canada. And in 2011, he was inducted into the Canadian Academy of Health Sciences for his outstanding achievements and contributions to the world of health sciences. Currently, he is the Chief Scientific Officer with the Lundquist Institute, or formerly known as LA Biomed, that is a not-for-profit research organization based in California. Dr. Madrenas is also a professor at UCLA, and he's had over 200 publications. Dr. Madrenas, please forgive me for only mentioning a fraction of your accomplishments. I welcome you to our program. We met exactly a month ago, and we're here again to discuss COVID-19 and any follow-ups. Thank you.
Thank you very much for having me again. It's my pleasure.
Dr. Madrenas, how do pandemics end?
Formally, the end of a pandemic is defined by the absence of any new cases after 2 incubation periods from the last case that turned up negative. In other words, in this particular case of the COVID-19 pandemic, we are considering a incubation period for the infection of 14 days. That is a rather conservative estimate. Most coronaviruses infections have an incubation period between 5 and 6 days. But in order to accommodate all the cases that we have seen, we put 14 days. So in terms of the formal end of the COVID-19 epidemic, it will be necessary to have 28 days without new cases after the last COVID-19 case has turned up negative for the virus. That would be the academic definition of the end of the pandemic.
But what happened to the virus itself? Is it because the virus has a 14-day, conservatively speaking, 14-day lifespan? And once, if it's not transmitted and it dies, is that when we saw the tapering off of the cases?
No, in fact, the period of incubation is the period of time that goes between the entry of the virus into an organism, into a body, until the appearance of the symptoms of a disease. That is what we call incubation period. Now, the idea is that for that particular individual, getting over COVID-19 means that the disease subsides and there are no more symptoms. But the virus in the community doesn't go away. Usually we'll have either a reservoir in a species or in several species, or what we are starting to consider is that there may be a percentage of the population that actually carries the virus but does not present any symptoms. The percentage of these group is currently, and again, that is as of today, this certainly can change, but currently is estimated to be around 20% of the population may be carrying the virus and not showing any symptoms of disease. Obviously, this number again will be confirmed or can change once we have the ability to do massive testing that would allow us to see in reality how many people have been exposed to the virus, may actually have the virus, and not be sick at all. Several studies are currently underway, one of them in Los Angeles, led by investigators at USC. And the idea is to measure antibodies that will be a reflection of having been exposed to the virus.
Very well. Doctor, hydroxychloroquine, that has been around since 1955. It's a malaria drug. It's been used for lupus and rheumatoid arthritis, but it has been a controversial drug of late. And that is because some doctors swear by it, that it has treated and cured their patients. And there are others who are very skeptical and claim that the side effects are worse than the treatment. What is your opinion of this drug in relation to treatment of COVID-19?
Yeah, this, I think, to be fair, the situation with hydroxychloroquine has to do mostly to the fact that the data is still tenuous, that we need to have what are called randomized clinical trials that will formally look at the potential effect that the drug may have in patients with COVID-19, and also see what would be the incidence of side effects under these conditions. Having said that, true, the drug potentially can cause serious side effects, mostly related to arrhythmias of the heart, as well as some impairment of the electrical function of the heart. But certainly this is something that has not precluded the use of this drug under other circumstances or in other conditions, like you just mentioned, lupus, or the treatment of malaria. So the idea is to have clinical trials that look at the effect of the drug, and in which these potential side effects are certainly closely monitored to make sure that the benefit, if there is a benefit of the drug, certainly outweighs any potential negative side effect that could have.
If you were a doctor treating a patient with severe symptoms of COVID-19 and their life was in jeopardy, would you opt to use this drug despite its side effects?
I think it would be fair as a general statement that under extreme conditions and when there is no other alternative, I think it's appropriate to use hydroxychloroquine. Having said that, I would never try to make scientific statements out of a single case. I would say that this is purely anecdotal and would not really be sufficient to claim that the drug can change the outcome of the disease. But again, on a particular case in which there is no alternatives, I think that the use of hydroxychloroquine may be justified.
Understood. Doctor, another procedure that has come to some people's attention is the process of pruning, which turning the patient on their stomach and hooking them up to the ventilator to treat coronavirus. Do you recommend that as well in certain circumstances?
I certainly, I think that our knowledge at this point is still very limited, and I would not be able to comment on that on a properly informed basis. I think that what we are seeing is that the need for assisted respiration through a ventilator is certainly an indicator that we are dealing with a very severe case, and we know that when combined with other risk factors, patients that go into a ventilator certainly do have much poorer prognosis than if they were not connected to a ventilator. Also, preliminary data, but again, is not conclusive, indicates that there may be a difficult process to wean out of the ventilator. Again, these are just preliminary pieces of knowledge that have to be properly assessed with a more scientific assessment, and for which we still do not have definitive data.
Is it because the ventilators have their own risk, or is it because
that's a good point. Yes, ventilators in itself may carry some or may have some side effects. I think, though, that in this case, the benefit truly outweighs the harm that may be seen under isolated cases. So I think that assisted respiration by a ventilator is certainly of a measure of benefit for patients that are under severe respiratory distress.
Absolutely. Doctor, could you tell us a little bit about herd immunity, which is being talked about quite a bit in relation to COVID-19? What is your opinion of it?
This is a very interesting concept that applies to pretty much every type of infectious disease, not only to COVID-19. The only thing is that for COVID-19, we are in a position to discuss approaches that may lead to it. So by herd immunity, one understands the situation by which a group of organisms, in this case a group of human beings, would actually get protection by having some of them immunized or having developed immunity to the infectious agent. Now, this subgroup of people that develops the immunity to the infectious agent may have developed the immunity by having the disease or because they have been vaccinated. So for COVID-19, we do not have a vaccine yet. So this subgroup of people would actually be immune because they have had the disease and have been able to overcome the disease. Okay? So as a result of having this group of people that are immune to the disease, the virus has a harder time to spread, because the chances that we'll encounter people that are immune are higher, therefore the spreading won't occur. So that already tells you that the more contagious a virus is, the higher the percentage of people that need to be immune in order to get herd immunity, right? So for example, people will remember about measles. People of my generation remember measles as a very contagious infectious disease. Well, for measles, actually, the percentage of people in a community that need to be immune before we get herd immunity is close to 95% or even higher. Okay? So that's why it's so important that for measles, people be vaccinated in order to contain and get this state of herd immunity. Now, for COVID-19, the initial estimates, again, these are estimates, but I think are starting to come consistently along these figures. The initial estimate is that we will need about 60%, 60% of the community immune to COVID-19 in order to have herd immunity. In other words, that the community is protected of COVID-19. At this point, we do not have any indication that we have reached that number. Okay, so again, we may be a way to go. I wouldn't say a long way, but a way to go. Now, having said that, if we reach that point, one would see that there is a community level protection, and that would be certainly a protective factor for individuals too. Now, herd immunity may reach a point of 100% and then lead to the elimination of a disease. That is what vaccination against smallpox was able to achieve. Okay? So thanks to very aggressive campaigns of vaccination against smallpox, we were able to eliminate the disease. There is no more smallpox on Earth as a result of vaccination. And now it is basically there is no chances of getting the virus transmitted, and therefore the virus has been eliminated, other than some laboratory stocks that are not significant in terms of the discussion we are having.
Doctor, let's talk about a scenario. Let's assume a person who has come into contact with COVID-19. However, he either tests negative for it or tests positive for it, but is asymptomatic. Is it possible that down the line, this person may have bad symptoms, life-threatening symptoms of the COVID-19?
Excellent question. So my short answer would be, at this point, we cannot definitively answer this question, but we can offer circumstantial evidence to try to address your question. And that is the following. COVID-19 is caused by a coronavirus that is called SARS-CoV-2. And we know that about 30% of the common colds every year are caused by coronaviruses. And for those coronaviruses, we know that there is a state of immunity, of protection, that usually lasts between 12 months, a year, to about, in some cases, up to 3 years, but more often than not, to a year and a half to 2 years max. Okay? So we know that for other coronaviruses, the exposure to the virus can lead to a state of temporary immunity, not permanent, but temporary. So someone that is exposed to the virus and basically develops immunity to it, and by that I mean we're able to develop protective mechanisms, either by antibodies or by immune cells that would kill virus-infected cells. Certainly, if that stage is achieved, then that person should be protected from COVID-19 if it is the same as with other coronaviruses for a period of 1 to 2 years. Okay. However, we do not know for sure okay, for COVID-19 yet. So that is something that we need to study and come up with a specific number and show that the presence of these antibodies really are protective down the line for this period of time.
Very well, thank you for that. Doctor, a lot has been talked about the number of the infected, the number of the hospitalized, the number of the dead. The number that hasn't been really talked about, or at least shared with the public, is the statistic and the data on the infected people or hospitalized people with the underlying conditions. Do you believe that if we know the breakdown of the underlying conditions of the COVID-19 infected or dead people, that we can make better decisions policy-wise in controlling the virus?
Well, it's interesting you point this question at this time. I mean, like you said at the beginning, we met about a month ago, 1 month to the date actually ago, and I was looking at the numbers when we first met in March 17 and the numbers today in April 17. So just globally, in March 17, we had 196,000 cases, confirmed cases of COVID-19. As of today, we have close to 2.1 million cases. That is an increase of about 10 times the number of cases in 1 month. Now, the number of deaths, the mortality that we have seen in March 17, it was about 8,000 cases. Currently, the total number of deaths, again, out of confirmed cases, is about 140,000. So we are looking at a situation right now in which the overall there has been an increase in about 10 times the number of confirmed cases and a little bit higher number of deaths as a result of these. And this is at a time in which, at least in European countries, we are starting to see a stabilization or a decrease for the number of cases. So that in itself is encouraging. But with what we know, with these numbers that I just gave you, it's clear that the presence of risk factors in older individuals, older than 65, and for which there is a requirement of assisted ventilation, a respirator, the mortality certainly increases dramatically. So from having a mortality overall around 3 to 4.5%, depending on the statistics, now we may actually be seeing that when the risk factors are present in an older population and the requirement of assisted ventilation is there, then the mortality is much higher, much higher. Just for senior citizens with risk factors, we are looking at a mortality that may be up to 20%. So that is
high,
significantly
Doctor.
higher. Yeah.
It's very high.
So remember that the flu usually has a mortality of about 0.1%. So we are really looking at a significantly higher mortality. What is interesting also is that we do see a different frequency of mortality or different mortality in different countries. For example, Germany is usually put as an example of a country with low mortality, similar low, about 1 to 1.5%. Same for the US or Canada as of yesterday. Compared to other countries like in Italy, Spain, or France, where you see mortalities between 7 and 10%. Now, I have to say that these figures or these numbers may be in part tainted by the fact that different countries have different testing policies. So we don't know how many people they are really testing out of the people that could have COVID-19. And also whether in terms of deaths, they are reporting all the deaths related to COVID-19. Although initially this is surprising, well, the reality is that there seems to be press reports from some European countries in which there have been cases of underreporting deaths from senior citizens' home, for example. So that is something that we will have to factor in when assessing these numbers. Altogether, what I am just trying to say is that the mortality for people with risk factors is significantly higher, and certainly is a cause of concern.
It certainly is. However, Dr. Birx of the White House Coronavirus Task Force, at one point she said that they were very liberal in reporting the rate of deaths among the people. So maybe later in the future we can look into the data and analyze it and come up with a more accurate figure of everything. Right now it's too difficult.
Exactly. And I think that this is why it's so important to ensure that testing for COVID-19 is not a limiting step. That is, to me, essential, that we do have an idea of what are the exact number of people infected by the virus, and certainly work on that number rather than having to work with different numbers or different criteria for the numbers that are being reported. The numbers I provided, though, are numbers of confirmed cases. Those are the numbers that the WHO is providing.
Yes. Doctor, we care a lot and talk a lot and focus a lot on the coronavirus infected people, the hospitalized people. However, a vast majority of the people, Americans, are not infected. However, due to lockdown, they are probably having other conditions. For instance, as a result of lockdown, people could be in their homes, depressed, anxious, suicidal, or maybe we do have suicides, cannot see family, loved ones, friends, drug abuse, alcohol abuse, overeating, obesity, lack of exercise, and so on and so forth. And children who are confined in their homes and have nowhere to burn off their energy, especially in a place like California with shut down parks and recreation places. And that also the fact that some business owners may never have their businesses vitalized again. And all this in the backdrop of our country's economy that some economists say will hurt badly in the future. Now, you as a scientist, let's assume you are an advisor to the president. How do you balance saving the people who are very sensitive and ill in the hospitals against a vast majority of Americans who are hurting in so many different ways? How would you balance that?
Yeah. Well, this is indeed a very difficult question. I think that the key point is that we know that social distancing and the confinement is working, because we have seen in countries in which they implemented it early and aggressively, the number of cases stabilizes and goes down sooner. So it is clear that the implementation of public health measures that promote social distancing, and enforce social distancing are essential. Now, a pandemic is not only characterized by the immediate clinical disease and the effect that the disease has on individuals on human beings, but also on many other factors that are associated with the spreading of the disease, factors that are of social, economic, and political characteristics. So one has to balance the medical aspects of the disease as well as the non-medical effects that the disease has. This is a complicated decision. What I can say is that the epidemiological approach to handle the pandemic is the same way as we started with confinement in a very stepwise approach, identifying steps that address different levels of risk. Deconfinement, that is going back to what could be a new normal, should also take a gradual approach. I don't think that this is going to end one day for another, letting everyone out. I think it would be counterproductive and disastrous, if you ask me. We need to have what I would call a gradual deconfinement. And that gradual deconfinement should take the measures implemented for deconfinement, but in reverse order. In other words, the first things that were shut down early on in the pandemic should be the last things that are open up when the pandemic ends. For example, large gatherings, sports events, movies, theaters, concerts. Another step close to that would be reopening the schools. And certainly letting people that are at higher risk or are in a high risk group to actually going out. These are the last group of individuals that should actually be going out. So my advice is to really come up with a plan that takes into consideration a gradual deconfinement in which individuals that need to carry essential activities and do not have any risk factors, or they have a low risk of infection, should be let out first, and individuals that are at high risk of infection and high risk of complications and do not carry or do not perform essential activities are let out the latest. That, in a simple way, would define a gradual deconfinement that I think would be the safest. I think it would be a mistake to drop the guard altogether at one point, especially when we have not seen a consistent decrease yet in the number of new cases. That's the case for the US at this point. It's just preliminary, it's plateauing. So we know historically, actually, that when cities or countries have reopened the confinement, in other words, have dropped the quarantine effect. It happened in some countries in the Spanish flu of 1918. It happened in London, England in the 1665 plague. What we see is a rebound of new cases. And certainly is not to the same extent as the first wave of disease, but is certainly significant. And this is something that could be avoided by making sure that there is a gradual deconfinement and it's not too soon.
Doctor, you mentioned that the healthy ones should be let out first. Do you advocate?
With no risk factors and
no
carrying essential activities, yes.
Do you advocate for testing before we allow those people to go out? Or it would be an individual responsibility on the part of Americans?
I think that under ideal circumstances, testing should be implemented in the deconfinement. That's what I said early on in the conversation, that I think that broad testing for the presence of the virus is essential in handling the deconfinement. I think that it should be under the auspices of a public health policy implemented by federal, state, and local officials. I think it would guarantee access to the testing, appropriate access to the testing for all the members of the community.
Doctor, some believe that the COVID-19 escaped from the two research labs in Wuhan, China. One of them is the Wuhan Institute of Virology. Being a COVID-19 board person myself, yesterday I went to their website and I looked at their website to see if they have any information on COVID-19, since they've been doing a lot of research for a long time on bats and other animals and the coronavirus. And to my surprise, there was nothing on their front page. There was a lot of HIV research information. So in their search box, I put in coronavirus, COVID-19, and I got zero. Nada for any information on COVID-19. And then I went to the partnership section and I looked at who the partners are with the Wuhan Institute of Virology. And to my surprise, there was Harvard in partnership with them, University of North Texas, NIH, who has paid $3.7 million to the Wuhan Lab, the World Health Organization, the European Union, the United Nations, many universities and organizations, Canadian, European, Australian, and even African, have in some ways been in partnership with that lab. As a scientist, doctor, when a research lab has received so much funds and maybe perhaps even researchers and scientists, do they have an obligation to allow other nations and other donors to go in and periodically check the conditions and see if things are being done properly, so we won't get into predicaments like this?
Yeah, I am not familiar to the specific policies that govern the communications by the Wuhan Institute of Virology. I think that the communication of scientific results should be done under the procedures that characterize scientific peer review of the results and subsequently free circulation of those results for the community to learn and to assess properly and certainly work on the basis of those results. I think that there is it is important for me to say that the suspicion that the SARS-CoV-2 that causes COVID-19 is the result of a viral or a virus that escaped a laboratory is completely false based on the evidence that we have. It is clear, and there are several studies that have shown that the sequence of the nucleic acid of the virus shows that it's not a laboratory, or it's not of laboratory creation. It's a natural virus that actually was able to move from a reservoir species, most likely bats, into an intermediate species, most likely the pangolin, and from that was able to jump and infect a human being, and from that subsequently spreading. So I think it is important that that the community and your viewers be reassured that this is not a laboratory created virus. It is actually a naturally occurring virus, and I would not raise any suspicion on its origin.
Very well. Doctor, my closing thoughts are that China closed off Wuhan as soon as they found out that this was an extremely contagious virus. However, they allowed people from China to travel across the world and infect the rest of us. And I think that's something that needs to be handled and discussed and controlled so that we will not have this in the future. It's very costly as far as lives and economical damage to all of the world.
I think that what you are pointing out is the fact that we live in a globalized world, and the facilities or the easiness in which one can travel from one end of the earth to the other allow for the spreading of diseases, infectious diseases, right? So planes would act as fans in the dissemination of these infections. So I think that that is independent on where it started. Similar situation could have started, out of any other country, and by the mobility of the people, spread to other parts of the world. I think that what we are seeing, and if you were to ask me what could be a public health measure that could change the outlook in moving forward, is of repeating this type of infections, is tries to eliminate or minimize these markets in which different species alive are maintained alive, so that there is an increased chance that viruses can go from one species to another and then infect subsequently other species, right? Again, we know that these type of coronaviruses live in bats, it is hard to see elimination of this virus, but it is possible to downplay or to minimize the chances that the virus will jump into an intermediate species and from that to a human. So if I were to recommend a measure along those lines, would be the closure of these type of markets where these animals are basically in contact to one another.
No wet markets anymore in China.
No wet markets.
That's your recommendation.
Yeah.
Doctor, I cannot thank you enough for your time.
My pleasure.
Your very wise answers. And I hope that we can get you back in about a month to do a follow-up. And
I think that for the LA County, we are looking at May 15 as the next major timeline or reference in terms of the timing and the management of this outbreak. And I think that hopefully will bring good news for everyone.
And hopefully it will be safe enough so the date will not be pushed back further.
Okay, let's hope so too. Yeah.
Thank you, Doctor.
My pleasure.
Stay safe.
Thank you. Okay, thank you.
مربان اتلی هیوی آویتون خامن دی لیپه خير من قمادية من دكتور مدريناس هم زملن عادية مدرهم زملن وعادية بويزودة مندي بدايخ باسد داها فيروس ويتلي هيفي عبيتون سلامت وخدي يوموخن عبي بشينه